next we will be discussing fungal infections. So second is fungal infections. Under this heading we will be discussing various superficial and deep fungal infections. First heading is superficial fungal infections. The first superficial fungal infection is pityriasis versicolor. If you just look at the name of this condition, you can remember so many points. Pityriasis term means scaling. And this scaling which is seen in this condition is very fine, rice powder like. So powdery scales are seen. Okay. Color, all of you know, versi means different. So different colors are seen. Different color means sometimes lesions are hypopigmented, sometimes they are hyperpigmented. So generally they are hypopigmented, but sometimes they can be hyperpigmented as well. They might ask you the reason for this hypo and hyperpigmentation. So remember, this hypopigmentation is due to azelaic acid. This azelaic acid is secreted by this Malassezia yeast. Okay, so Malassezia yeast, which causes pityriasis versicolor, secretes this azelaic acid, which is a tyrosinase inhibitor. While hyperpigmentation is due to increase in size of melanosomes. So due to increase in size of melanosomes, sometimes lesions can be hyperpigmented as well. So just from the name of this condition, you know these points, that sometimes hypopigmented, sometimes hyperpigmented lesions might be present in pityriasis versicolor, and these lesions have scaling, very fine powder like. If we talk about the causative agent, it is caused by Malassezia globosa, also by Malassezia furfur. Clinically, the lesions are perifollicular. So perifollicular, that is around hair follicles. Okay, so perifollicular, hypo, sometimes hyper, pigmented, macules or patches. See, you already know what are macules. Macules are neither raised nor depressed, less than 0.5 centimeter in size. These are very small flat lesions. Okay, so if these are the hair follicles, around these hair follicles, these small macules start developing. Now what happens, that these keep on increasing in size. So gradually they keep on increasing in size, and when they increase in size, they might merge together. So when they merge together, they form a large lesion. So small lesions are known as macules, large lesions are known as patches. So you might get macules or patches. Over, site, upper trunk. So usually upper trunk is the site, that is upper chest, back, shoulder, neck area. This is the common site which is involved. Scaling, I already told you, very fine rice powder like or simply powdery scales are seen. Now because these are very powdery or fine scales, many a times they are not visible. So if they are not visible, you can simply with your nail scratch the lesion, and when you scratch the lesion, these powdery scales comes out. So this is known as scratch sign or coupe d'angle sign. Okay, so this is one sign which you can elicit. Investigation, because this is fungal infection, you can simply do 10% KOH mount and you will find short fungal hyphae with fungal spores. So short fungal hyphae with fungal spores are seen. Now these short fungal hyphae, they look like noodles. And these fungal spores, they look like meatballs present in them. So this gives spaghetti and meatball appearance. They might also resemble fruits like banana and grapes. So this is the characteristic appearance which is seen on 10% KOH mount. Another investigation which you can do is Woods lamp examination. I already told you yellow fluorescence is seen, but if yellow is not in the option, you can choose apple green. If we talk about the treatment of this condition, initially we give topical treatment. Topical treatment can be given in the form of azoles. So you can use ketoconazole, then selenium sulfide is also topically used in these cases. If they are not responding to your topical treatment, you can use systemic treatment in the form of again azoles like fluconazole, 400 mg 1 tablet stat. The important point to remember here is that griseofulvin, which is oral drug, so this oral griseofulvin is not effective in these cases, so it should never be used. Okay, so this is not effective in pityriasis versicolor, that is this Malassezia infection. Another point to remember is Whitfield ointment. Now this was used in past, this is no longer used, this is old treatment which was used in past. So previously this ointment was used, which is a combination of 3% salicylic acid and 6% benzoic acid. So this combination of 3% salicylic and 6% benzoic acid is known as Whitfield ointment. Okay, so what we do in pityriasis versicolor patient, we apply this acid over the skin. Okay, so when you apply this Whitfield ointment or acid over the skin, what happens? This acid percolates into the skin, it denatures the cells, and these superficial denatured cells, they start sloughing off and it is replaced by normal skin from below. So what is happening is skin resurfacing, and due to this skin resurfacing, what happens? The superficial fungal infection also gets sloughed off. Okay, so that is how it works, but it is no longer used. Why? Because this causes various side effects. Like when you apply acid over the skin, it is going to cause burning sensation, irritation, sometimes it might leave behind pigmentation. So these are the side effects due to which this is avoided and it is no longer used. Then the second superficial fungal infection after versicolor is Tinea nigra. Tinea nigra is caused by Pheoanellomyces wernicki. How they present? They present with black patch over palm. So generally palm is involved and you will find this dark black patch over palm, and it is treated with topical ketoconazole. These are the only points which you need to remember in this condition, because this is not common in India. This is commonly seen in Western countries. Okay, so just remember the causative agent and what is the presentation. It is black lesion which is seen generally over palm, and if you apply topical antifungals, it resolves. Let us move on to more common condition like candidiasis. Now candidiasis, all of you know, is caused by Candida albicans. Or Candida glabrata. Now clinically there are so many types of candidiasis. Okay, like first is oropharyngeal candidiasis or simply oral candidiasis. This is further divided into subtypes like acute pseudomembranous. This is the most common type, commonly known as thrush. Second is acute atrophic candidiasis and chronic atrophic candidiasis. Both these are atrophic variants. Okay, so because both these are atrophic variants, they present with red colored lesions. So once this question was asked that red colored lesions are seen in which type of candidiasis? So acute atrophic as well as chronic atrophic. Now this chronic atrophic type is commonly seen in old individuals who wear dentures. So this is also known as denture candidiasis. Then chronic hyperplastic candidiasis. Chronic hyperplastic candidiasis is common in smokers. And last one is paralysis, which is candidal infection of angle of mouth. So this candidal infection of angle of mouth is also known as paralysis. So these are various types of oral candidiasis. Then second is vaginal candidiasis. Now these patients of vaginal candidiasis, they present with vaginal discharge, okay, and whenever patient comes with vaginal discharge, sometimes we include this in sexually transmitted infection, because there is STI that is labeled as a vaginal discharge syndrome, and there is a NACO kit available which is green in color, which is given for these patients, okay. So this vaginal discharge can be of various types and there can be different reasons. So let us discuss them all together here. So whenever patient comes with vaginal discharge, one of the reason can be candidiasis. It can be due to trichomoniasis, or it can be due to bacterial vaginosis. Candidiasis present with creamy, curdy discharge. Trichomoniasis presents with greenish, frothy discharge with lot of itching, and bacterial vaginosis present with foul smelling, scanty, adherent discharge. Candidiasis treatment is fluconazole, 150 mg, 1 tablet stat is sufficient. While both these conditions can be treated with a single drug, that is secnidazole. Two gram stat, 1 tablet. So if you give these two drugs in a patient suffering from vaginal discharge, you can take care of all the three conditions. So this is known as syndromic management, where when you are sitting at a peripheral health center and you don't have lab facilities available and you cannot diagnose a specific disease, you can at least treat the syndrome by giving the treatment together. So if you give both these drugs, then you will treat the vaginal discharge syndrome, that is all the three conditions. So that is why National AIDS Control Organization NACO have provided this kit number 2, which is green in color, and this kit number 2 have these two drugs, that is fluconazole and secnidazole. So this is the syndromic management of vaginal discharge. Sometimes students find it difficult to remember these clinical features, so remember C for C. So candidiasis present with creamy, curdy discharge. Then you can remember TGI Friday, which is a famous pub. So trichomoniasis, greenish, itchy, frothy, and bacterial vaginosis. You can remember one sentence: whiff the clue of foul play. So if you are a detective, you can sniff the clue of foul play, isn't it? So whiff the clue of foul play. Here whiff test, clue cell and foul smelling discharge is seen. So in gynae you might have read about clue cells and whiff test, that is the amine order which comes out on pouring 10% KOH in the smear which you have prepared from the vaginal discharge. So these are two more points to remember in bacterial vaginosis. So first we have discussed oral candidiasis, second was vaginal candidiasis, next is candidal paronychia. Paronychia, I already told you, infection of nail folds, okay. So acute paronychia is generally bacterial, but chronic paronychia is candidal. So if there is candidal infection of the nail folds, it is known as candidal paronychia. Similarly, candidal intertrigo. So intertrigo, very obvious from the name itself, it is candidal infection of intertriginous areas. Intertriginous areas like axilla, groin, inframammary folds, then web spaces, in between the toes. Okay, so these are the sites which are involved in candidal intertrigo. And in infants, they have very short neck. Okay, so that's why in infants they develop candidal infection of neck folds. Now remember one very important point here. Satellite lesions. Satellite lesions are seen in BT type of Hansen's disease, that is leprosy, sporotrichosis, and candidiasis. So let us consider that this is a lesion of candidal intertrigo. Okay. Now if this is the primary lesion, many a times what happens, these smaller secondary lesions start developing around the primary lesion. So these secondary lesions which start developing around primary lesion are known as satellite lesions. Satellite, very much like satellite, isn't it? So there is Earth and there are various satellites revolving around it. So a large lesion in the center and various small satellite lesions in the periphery. Okay, and these are the conditions where these satellite lesions are seen. You can very easily remember by this simple mnemonic, that is satellite lesions are seen in BSc. Bachelor of Science, isn't it? So if you are desiring to launch a satellite, so your ambition is to launch a satellite, become a scientist, what you need to study first? You have to be a Bachelor of Science, isn't it? So you need to study science, BSc. Next is investigation. If you prepare 10% KOH mount, you will get pseudo hyphae. Treatment. The drug of choice for this condition is fluconazole. Again remember that griseofulvin is not effective. So griseofulvin is not used. After candidiasis, next is trichomycosis nodularis. If you recall, in bacterial infection we read about trichomycosis axillaris. There the mycosis term was misnomer because that was a bacterial condition caused by Corynebacterium. While here this mycosis is not a misnomer, this is a fungal condition. Okay, so remember, trichomycosis axillaris is bacterial, trichomycosis nodularis is fungal. Let us consider this is the hair follicle. So tricho means hair follicle, mycosis means fungal, nodularis means nodule. So you will find a fungal nodule attached to this hair follicle. So this is trichomycosis nodularis, where a fungal nodule is seen attached to hair follicle. This is also known as pedra. So another name of trichomycosis nodularis is pedra, which can be of two types. Black, also known as dark pedra. White, also known as light colored pedra. So pedra can be of two types. It can be black pedra or white pedra. These are few differentiating features. Like causative agent for black pedra is Pedrae horti, while white pedra is caused by Trichosporon bijli species. Okay, so Pedrae horti causes black pedra while Trichosporon bijli causes light pedra. Can you tell me why? Because wherever there is bijli, there is light. So simple to remember. Okay, so bijli species causes light pedra. Similarly, you look hot in black dress, isn't it? So horti, black. Okay, so these are so simple to remember. If you look at the hair follicles, you will find generally scalp hair are involved in black pedra, while axillary and pubic hair are involved in light pedra. Now the treatment for both these conditions is same, and the treatment is shaving of hair. So shaving is the treatment. Now why we shave the hair follicle? The reason is, if this is the hair follicle and this is the fungal nodule, this fungal nodule is not just attached to the hair follicle, it is intruding within the hair follicle as well. due to which what happens that if you treat it with antifungals, what happens, the inner fungus remains and it regrows. So recurrences are there despite treatment. So best is to get rid of such hair follicle. So shaving is the best treatment. If you shave the hair follicle, all the nodules are gone. But many a times shaving is not accepted by the patient as treatment, isn't it? Like in females, they are not going to go ahead with shaving. So in such cases, you can simply give topical antifungals. But remind the patient that with topical antifungals, chances of recurrences are there. Let us see few images. Like here you can see the patient is having this white membrane over the buccal mucosa. This is what? This is oral candidiasis. Here this is a patient of pityriasis versicolor where these small macules are seen. At places they have merged together to form a large patch. So these are the cases of pityriasis versicolor. As I told you, versicolor, different colors. So generally they are hypopigmented, but sometimes hyperpigmented lesion might also be present. Site commonly is upper trunk, so upper chest, upper back, shoulders. If you prepare 10% QH mount, you will get spaghetti and meatball appearance. You can see these septate hyphae or mycelia which looks like noodles, and you can see these small fungal spores which look like meatballs present in them. Similarly here you can see this mycelia and these are the meatballs. So oral candidiasis, as I told you, the most common type is acute pseudomembranous type. So this is the acute pseudomembranous type of oral candidiasis where this white membrane is seen. This is a pseudomembrane. Why it is a pseudomembrane or false membrane? Because if you take a gauze piece and start rubbing this membrane, it get detached. Okay, so this is a false membrane or a pseudomembrane. Then candidal intertrigo, I told you here the intertriginous areas are involved. Okay, so intertriginous areas like in infants neck fold. So you can see neck fold involvement. So this is candidiasis here. Similarly here, this is again of the web spaces. So this is candidal intertrigo. Then candidal vaginitis presents with curdy creamy discharge. And trichomycosis nodularis, which is also known as petra, here you will find these nodules attached to the hair follicle. So you can see these nodules, these are the fungal nodules which are attached to the hair follicle. Now you can write down one important fact here. Infants, they might develop diaper rash as well as pseudo diaper rash. So diaper rash are due to contact irritant dermatitis. So this is a dermatitis or the inflammation of the skin which occurs due to contact to the irritant material of the diaper. While pseudo diaper rashes are candidal infection of diaper areas in infants. So candidal infection of diaper areas in infants is known as pseudo diaper rashes, while contact irritant dermatitis of the diaper area is known as diaper rashes. This is due to the material of the diaper. Now how you are going to differentiate these two conditions, because the site is same, both occur in infants, both are involving these diaper areas. The important differentiating feature is look at the skin folds, because diaper are not going inside the skin fold, so it is not going to cause dermatitis there, but the candidiasis have tendency to involve the skin folds, that is the candidal intertrigo. Okay, so that's why if you examine the skin folds, so intergluteal fold or genitocrural fold, you will find that the folds are spared in diaper rashes, but they are involved in pseudo diaper rashes. Now the next superficial fungal infection is dermatophytosis. Dermatophytosis is caused by dermatophytes, and there are these three different types of dermatophytes: trichophyton, epidermophyton, and microsporum. Now these three different types of dermatophytes, they can cause infection of skin, hair and nails. But one among these do not involve hair and one among these do not involve nails. Can you tell me which one is that? So remember, microsporum never involves nails and epidermophyton never involve hair follicle. Now this is a very important point to remember. Why? Because sometimes questions are asked, like they might ask you, onychomycosis is not caused by which of the following agent. Okay, now you know onychomycosis, that is fungal infection of nails, and you also know that microsporum do not involve nails. So if you find microsporum in any of the options, you can choose that as answer. So you can answer these questions very easily if you just remember these 2 points. Okay, but sometimes by the time you reach examination hall, you forget these points. Okay, so if you forget these points, you can very easily recall, because this is so simple to remember. Microsporum do not involve nails. Why? See, this is very much like us, like we all love our near and dear ones, isn't it? So we all love our near and dear ones. I hope there is no exception to this, and we never try to adversely affect them. So are these species. Okay, so they also do not adversely affect their near and dear one. So you just need to find out which is the near and dear one of microsporum. So what comes near M? N. So it never involves N. What comes near E? H. So it never involves H. And in trichophyton, tri is written. Tri means all three. So trichophyton involves all three. So this is so simple to remember. Trichophyton involves all three. E do not involve H and M do not involve N. Now these dermatophytes, they cause tinea infection. And this tinea infection, depending on the site involved, can be of various types. So the important dermatophytosis is tinea. Let us consider this is your patient. Now this patient of yours developed tinea infection of scalp. So you will label it as tinea capitis. But if only beard area is involved, then you can call it tinea barbae. If nails of the patient are involved, then it is tinea unguum. If hand of the patient is involved, it is tinea manum. If sole of the patient is involved, it's tinea pedis. If groin is involved, then it's tinea cruris. And if rest of the body is involved, it's tinea corporis. So you can see that depending on the site involved, tinea can be of various types. If scalp involvement is there, tinea capitis. If beard is involved, tinea barbae. If nails are involved, tinea unguum. If hand is involved, tinea manum. If sole is involved, tinea pedis. If groin is involved, tinea cruris. And if rest of the body is involved, it is tinea corporis. Now tinea cruris is common in dhobis, washers, because they sit and wash their clothes and their groin area becomes wet. So this is also known as dhobis itch. Then tinea pedis is very common in athletes because they keep on wearing their shoes for many hours in a day and they develop tinea of foot. So this is known as athlete's foot. Then tinea corporis is also known as tinea cercinata. See why it is known as cercinata? Because you can write down few points here. Let us first write down about tinea corporis. See, this term cercinata means annular. So here annular itchy lesions are seen. So annular itchy lesions are seen in tinea corporis. What is annular lesion? Such oval shaped lesion is annular lesion. It has active margins and central clearing. So because the central area of the lesion is clearing and the margins are active, it looks like a ring. That's why this is also known as ringworm infection or ring infection. Okay, so such ring is seen, such annular lesion is seen. So such itchy annular lesion is seen in tinea corporis and the characteristic feature is central clearing. Similarly, they might ask you that central crusting is seen in, it is seen in leishmaniasis. Central scarring is seen in lupus vulgaris, which is the most common type of cutaneous tuberculosis. So these are three very important points to remember. Central clearing is feature of tinea, central crusting is feature of leishmaniasis, and central scarring is feature of lupus vulgaris. Then sometimes they might ask you about tinea imbricata. Tinea imbricata is caused by Trichophyton concentricum. Trichophyton concentricum. And in this type, what happens that, as I told you, in Tinea corporis there is one active margin. Here there are multiple active margins which are concentric to each other. So this is so simple to remember. It is caused by Trichophyton concentricum. So multiple concentric margins are seen, and such type of tinea is known as tinea imbricata. Then sometimes they ask you about tinea incognito. Tinea incognito. Cognito means recognition. In means un. So unrecognizable. This is a tinea which is not clearly visible. Why? Because of steroids. Okay, so under the effect of steroids, symptoms like itching and inflammation like redness subside, but infection, that is 10% QH mount, will come out positive. Infection present. So if you find such clinical picture, that is symptoms are absent, patient comes and tell you that there is no itching, there is no redness, but when you do KOH mount it comes out positive, that means infection is there. So what this suggests? This suggests that patient is applying steroids. So what happens is steroid is anti-inflammatory, so inflammation subsides, but the infection is still there and it is spreading. As soon as patient stops applying steroid, this tinea flares up. So this is what? This is a hidden tinea. This is incognito. So this is known as tinea incognito. Okay, have you read this term elsewhere? Incognito. Incognito. When you log into your Gmail account, you might have seen on the right upper side, go incognito, isn't it? So if you click there, what happens? A separate window opens, and if you log in through that, you are not shown online in the Gmail chat, isn't it? So that is a hidden mode, that is a private mode. And if you open anything from that incognito window of Google, that will be not shown in the history also. Okay, so that is incognito, that is, it is not visible. So that is hidden. Similarly here, tinea incognito, this is not visible, this is hidden tinea. Now, among various tinea infections, tinea capitis is very important. So we are going to discuss this in detail. It can be of two types, inflammatory and non-inflammatory. Inflammatory is further divided into two, carrion and favus, while non-inflammatory is also divided into two, black dot and grey patch. Carrion. Here there are few points which you need to remember. First, this is common in children. Patient presents with tender boggy swelling. Presents with tender boggy swelling. Easily pluckable hair. Easily pluckable hair. Associated with regional lymphadenopathy. So these are four very important points to remember in carrion. This is common in children. Tender boggy scalp swelling is present. Easily pluckable hair are there, and regional lymphadenopathy might be enlarged. Like recently this question was asked that 10-year-old boy present with boggy scalp swelling, easily pluckable hair, multiple sinus, enlarged occipital lymph node. Which investigation you will do? One of the option was 10% KOH mount. Okay, so these are four very important points to remember. So this is very common in children. These children present with tender boggy swelling and easily pluckable hair and enlarged lymph node. Now whenever this presentation comes to you, that is child with tender swelling and enlarged lymph node, sometimes we think of bacterial infection, isn't it? But this is not bacterial, this is fungal infection. So sometimes we get confused with bacterial abscess. So how to differentiate? See, bacterial abscess is very painful, isn't it? So if you pull the hair of a child, suffering from bacterial abscess, what will happen? He will pull yours, isn't it? It is so painful. But in carrion, there is no pain. If you pull the hair follicle, they easily come out. Okay, so this is one important differentiating feature. Favus, this is common in residents of Kashmir. They present with thick crusting over scalp known as scutula. So scutula is seen in favus. This is common in residents of Kashmir, and thick crusting is seen. Now black dot type is caused by endothrix species. See, there are two examples, endothrix and ectothrix. So if the fungal spores are inside, we call it endothrix. If they are outside, we call it ectothrix. So endothrix species, these species which have spores inside the hair follicle. So when the spores are inside the hair follicle become very weak and they start breaking off. So let us consider this is the hair follicle. And due to the fungal infection, lot of fungal infection is there. So this hair follicle becomes weak and it breaks just at the level of scalp. Okay, so let us consider that this is the scalp of the patient. This is the site from where the hair follicles are breaking, and in this site you will get multiple black dots, isn't it? What are these black dots? These are those broken hair follicles, isn't it? Because these hair follicles, they are breaking just at the level of scalp. So this is the point which you need to remember, that hair follicles, so in black dot you can write down hair follicles break just at the level of scalp, giving black dot appearance. So black dot appearance is seen. Now gray patch, this is caused by ectothrix species. So this is caused by ectothrix species. So here the spores are outside. So they also make the hair follicle very weak and they start breaking, and they break above the level of scalp. So when they break above the level of scalp, you will find a patch of broken hair follicles, isn't it? And this patch of broken hair follicle have scaling also, so it appears grayish in comparison to the remaining scalp. So here again you can write down hair follicle breaks above the level of scalp, giving gray patch appearance. So here gray patch is seen and there black dot is seen. So these are 4 different types of tinea capitis. Now the common causative agents which cause carrion are trichophyton mentagrophyte and trichophyton verrucosum. While favus type is commonly caused by trichophyton Scholleni. Now Scholleni species is the most common species causing favus, so generally question is asked on this. Trichophyton tonsurens and Trichophyton violaceum are the common agent causing black dot, while Microsporum canis is the common causative agent for grey patch type. So these are the common causative agents for these different types of tinea capitis. Investigation which you can do here is Woods lamp examination. I told you on Woods lamp examination, green colored fluorescence is seen. Green fluorescence. Now remember that this green fluorescence is not seen in all the cases of tinea capitis. The reason is that there are few fluorescent species and few are non-fluorescent species. So if there is fluorescent species which is causing tinea capitis, you will get green fluorescence, otherwise you will not get. So remember that Microsporum, so all the Microsporum species and Trichophyton Scholleni species are fluorescent. Okay, so all the Microsporum species and Trichophyton Scholleni species are fluorescent. So if the patient comes with favus and the causative agent is Scholleni, then you will get fluorescence. While if the patient is suffering from black dot and the causative agent is tonsurens and violation, you won't get green fluorescence. Okay, so remember this point. Treatment. Oral griseofulvin is the drug of choice for tinea capitis. So drug of choice is oral griseofulvin, which is given 10 to 15 mg per kg body weight. But according to a recent article in British Medical Journal, they have mentioned that depending on the type of dermatophyte, the drug of choice might vary. So like if trichophyton is the causative agent, then the drug of choice will be terbinafine. If the causative agent is Microsporum, then drug of choice will be griseofulvin. If griseofulvin is not given, you can choose itraconazole. Okay. Now why we have not written epidermophyton? Because I told you E do not involve H. So because it do not involve hair, it will not cause tinea capitis. Okay. So these are the two important dermatophytes which cause tinea capitis, trichophyton and microsporum. If trichophyton is the isolated species, then you can choose terbinafine, and if microsporum is the isolated, then it is griseofulvin. But if nothing is mentioned, only simply they are asking what is the drug of choice for tinea capitis, then mark griseofulvin. Now these are few important facts to remember. Like they might ask you that which is the most common ectothrix species causing tinea capitis. Answer is Microsporum canis. Which is the most common endothrix species causing tinea capitis? Trichophyton tonsurens. Which is the second most common endothrix species causing tinea capitis? Trichophyton violaceum. Which is the most common causative agent for tinea capitis in India? Trichophyton violaceum. Which is the most common causative agent causing tinea capitis in Western countries? Tonsurens. Which is the most common causative agent causing tinea capitis around world? Microsporum canis. So these are 6 important points which you can remember, that which is the most common ectothrix, Microsporum canis, which is the most common endothrix, tonsurens, second most common if tonsurens is not there in the option, violaceum. In India most common is violaceum, in Western countries most common is tonsurens, and around world overall most common is Microsporum canis. Now sometimes the student find it difficult to remember, and that is the reason why I have arranged them like a palindrome. As you can see, canis, tonsurens, violaceum, then violaceum, tonsurens, canis. Okay, so just remember 3 and then reverse the order. Now all of you might be having television at your home. TV is inside the home, isn't it? So endo species are T and V, and in TV T comes first and then V. So most common endo is T, second most common endo is V, and remaining is C. C is ecto. So you can very easily remember C, T, V. So C is ecto, endo is T, V, and then VTC, that is India, Western world. So this is so simple to remember: ecto, endo, second endo, India, Western world, C, T, V, VTC. Okay. Then they might ask you that which is the most common causative agent for tinea cruris, tinea corporis, tinea manum, tinea pedis, tinea unguum. So for all these, the causative agent is same, that is Trichophyton rubrum. Okay, so for tinea cruris, corporis, manum, pedis and unguum, the causative agent is same, and that is rubrum, and that is the reason why the drug of choice for all these is also same. The drug of choice for all these is oral terbinafine. If terbinafine is not given, choose itraconazole. The doses are generally 250 mg. This is given once daily. This is 100 mg given twice daily. Duration of therapy for majority of them is 4 to 6 weeks. After tinea capitis, next is tinea unguum, which is also known as onychomycosis. Onychomycosis. See, onycho means nails, mycosis means fungus. So this is fungal infection of nails. Unguum means nails, and tinea is for dermatophytic infection. So this is dermatophytic infection of nails. Okay, so onychomycosis is a broader term which is all fungal infection of nails, which includes dermatophytic as well as non-dermatophytic, while tinea unguum is only dermatophytic fungal infections of nails. Okay, so sometimes what happens, candidal infection of nail occurs. So that is candidal onychomycosis, that is the non-dermatophytic onychomycosis. Now there can be three different types of onychomycosis. First one is known as DLSO, which stands for distal lateral subungual onychomycosis. Second is PSO, proximal subungual onychomycosis, and third is SWO, superficial white onychomycosis. This DLSO is the most common type, PSO is the rarest type, and this is seen in HIV positive patients. So these are three different types of onychomycosis. Most common is distal lateral subungual onychomycosis. Rarest type is proximal subungual onychomycosis. This is common in HIV positive patients, and third one is superficial white onychomycosis. Let us try to understand this. Let us consider this is the nail of the patient. This is the transverse section. If you recall, while discussing nails, I told you that which is the most common site where fungal infection occurs first in the nails. Okay, so which is the most common site for onychomycosis? Yes, it is hyponychia. This is the site, that is the distal and below the nail. This is hyponychia. This is the most common site for onychomycosis, isn't it? So hyponychia is the most common site for onychomycosis. So whenever fungal infection occurs, the first site which is involved is hyponychia. So hyponychia is distal and below the nail plate. So distal area is involved first, isn't it? And it is below the nail, subungual. So distal, little bit of lateral, and below the nail, subungual. So that's why this is the most common type. But in HIV positive patient, in immunocompromised patient, the proximal part of the nail is involved first. So this is known as proximal subungual onychomycosis. And if only the superficial part of the nail plate is involved, then this is known as superficial white onychomycosis. So these are three different types of onychomycosis: distal, proximal, and superficial. Now all these three different types of onychomycosis ultimately lead to complete nail involvement if it is not treated. Like from distal it will progress to proximal, from proximal it might progress to distal, from superficial it can go to deep. So it can ultimately lead to complete nail dystrophy. This is known as total nail total dystrophic onychomycosis. So ultimately it can lead to total dystrophic onychomycosis. Treatment here is again same, that is I told you oral terbinafine and oral itraconazole. Okay. Now the dose is slightly different. Why? Because here we need to give this for a very long period. Okay, so if you keep on giving daily, then it might lead to side effects of these drugs. So that's why we give pulse therapy. Pulse. And when we give pulse therapy, we double the dose. That is, if you are using terbinafine 250 mg instead of OD, we give BD, and itraconazole we give generally 100 mg BD. Here we give 200 mg BD. So double the dose for 7 days every month. So what we are doing, we are giving drug for 1 week and then there is a gap of 3 weeks. Such 3 cycles are given. So at least 3 cycles are given in onychomycosis. Then there are few topical agents which can be used. Topical agents like amlorphin, cyclopyroxalumin. Both these are available in the form of nail lacquer. Because if you apply any lotion, solution, cream over the nails, it is not going to stay and it is not going to penetrate into the nails. So we require agents which stay there over the nails for a longer period, like nail paints, isn't it? Once you apply over the nails, they stay there for many days because they are nail lacquers. Similarly, these agents are also available in the form of nail lacquer. They come in a small glass bottle with brush. So like nail paint, you simply need to apply over the affected nail, leave it for 1 week, then file the nail and reapply. So weekly application is done. Next, we will be discussing deep fungal infections. Under D fungal infection, the first one is sporotrichosis. Sporotrichosis is caused by sporothrix. There are 3 clinical variants of this condition which have different clinical features and different drug of choice. Like the first one is cutaneous variant. Cutaneous variant present with nodule with ulceration, and the drug of choice itraconazole. Second is lymphatic. Lymphatic variant is considered as the most common variant where linear nodules are seen. Linear nodules with satellite lesions. This is treated with saturated solution of potassium iodide. This is given orally. Now, because we are giving saturated solution of potassium iodide in body, it gets converted to iodine and it can lead to iodine related side effects. So, due to safer alternative, we prefer itraconazole. But since saturated solution of potassium iodide is inexpensive and cheap, it is still used in sporotrichosis and it is very effective, and that's why many a times examiner wants to ask you about this. So, if itraconazole is not there in the option, choose saturated solution of potassium iodide. Third is systemic variant. In systemic variant, due to inhalation of this agent, lung involvement might be seen. This is treated with amphotericin B. Let us try to understand this. See, sporotrichosis, you might have read in microbiology also that it is also known as rose gardener's disease or rose thorn disease. Why? Because wherever this rose thorn pricks, at that site of inoculation, this nodule is formed. Okay, so this is rose gardener's disease or rose thorn disease. So this is very common in gardener and florist, and at the site of rose thorn prick, these lesions start developing. Okay, so generally they develop over exposed parts. So let us consider if the inoculation occurs here, a nodule will be formed here. Okay, so this first nodule is known as cutaneous variant, but many a times what happens, this agent enters into lymphatic system and along proximal lymphatic it produces multiple nodules. So if you get linear row of nodules along lymphatics, that is lymphatic variant. Okay, and sometimes due to inhalation of the agent, lungs are involved or other organ get involved, then this systemic variant is treated with amphotericin B. So these are various variants. If you do histology from any of these lesions, you will get asteroid bodies, drug of choice for this condition we have already discussed. Next is chromoblastomycosis. Chromoblastomycosis. The causative agent for chromoblastomycosis are Fonsesia group of fungus like Fonsesia pedrosi, Fonsesia compacta, Phyllophora verrucosa. Because this is commonly caused by Fonsesia group of fungus, this is also known as Fonsesia disease. Clinically, you will get verrucous. Verrucous means rough surfaced warty growth. So, verrucous or warty growth. They sometimes become very large, which may enlarge and give rise to giant cauliflower-like growth. Giant cauliflower-like growth. If you do histology from these lesions, you will get medulla, also known as copper penny bodies or sclerotic bodies. Drug of choice for this condition is itraconazole. So I told you that there are various species, some are endothrix, some are ectothrix. So if this is the hair follicle and all the fungal spores are inside, then we call it endothrix. If the hair shaft is intact and the spores are outside, we call it ectothrix. This is the carry-on type of tinea capitis, where you will find this tender boggy swelling over scalp in a child, and see there is hair loss. So this is inflammatory type of tinea capitis. So when it will heal, it will lead to scarring type of hair loss. And if it is non-inflammatory, then it leads to non-scarring type of hair loss. So remember that in tinea capitis, both the types of hair loss can occur. If it is inflammatory type, it will call scarring type of hair loss. If it is non-inflammatory type, it will cause non-scarring type of hair loss. That's why carry-on and favors cause scarring, while black dot and grey patch causes non-scarring. So here scarring hair loss will occur, and there will be easily pluckable hair. That's why most of the hair follicles are lost. So even when the patient comb the hair or simply pull the hair, they come out. Then this is another variant of tinea capitis. Here again you can see that there is hair loss. This is non-scarring type of hair loss, and you will find this patch with slight scaling, and there are broken hair follicles. So this is grey patch type. Then tinea pedis, this is interdigital type. Okay, so you can see in between the digits, tinea pedis. Remember, tinea pedis is not very important, but there are few variants of tinea pedis, or simply the types. Like first is interdigital, as you can see here, interdigital type. This is the most common type, but there are few other types also, like squamous type. Squamous is very clear from the name itself. Squamous, that is scaling is present. Then bullous type and ulcerative type. Ulcerative is the rarest type. So it can be interdigital, squamous, bullous and ulcerative. Interdigital is the most common type. So interdigital, that is web spaces in between the digits, this infection is present. If you recall, in candidal intertrigo also similar picture is there. Tinea pedis also have similar picture. So what is the difference? You can simply do KOH mount, and if you get dermatophytes, then it is tinea pedis. If you get candidal pseudohyphae, then it is candidiasis. Clinical picture might be sometimes same. Then tinea pedis, I told you there is one squamous type also where scaling is seen. So if you get scaling on foot, then this is tinea pedis. Now when tinea manum occurs, tinea manum, remember that tinea manum is generally unilateral, presents with scaly, hyperkeratotic and hyperlinear palm. So what happens? Tinea manum is generally unilateral. So one hand is involved, one hand is spared. As you can see, this is involved, this one is spared. Okay, so this combination is generally seen where the patient is suffering from bilateral tinea pedis and unilateral tinea manum. This is also known as 2 feet 1 hand syndrome. Why? Because this is usually seen in security guards or military personnel who keep on wearing their shoes for many hours in a day. So what happens? They develop tinea pedis in both the feet. Now because this is a very itchy condition, whenever they get time, they take off their shoes and start scratching it. Okay, and they use which hand for scratching? Their dominant hand, that is right hand. So you can see right hand is having tinea manum, left one is spared. Then tinea cruris, I told you here the lesions, I told you in tinea the lesions are generally annular and they have active margins. So you can see margins are appearing slightly active, and in the central portion there is slight clearing. So active margins are there. So ring like lesion is there, and if groin is involved, we call it tinea cruris, also known as Dhobie's itch or Jock's itch. Here again you can see characteristic lesion of tinea corporis. Tinea corporis have annular lesion with active margin, and there is central clearing. So central clearing, active margin. Here again you can see annular lesion, active margin, central clearing. Then onychomycosis, when nail involvement occurs, what happens? You will find that due to fungal infection of the nails start breaking and they become very brittle and fragile, and there is onycholysis. Onycholysis means nail starts separating from the underlying nail bed, due to which you can see this leukonychia, whitening of the nail. So this white nail is leukonychia, and this separation of the nail, this is onycholysis. This can be seen in this nail also. Then I told you there are 3 types. If the distal portion of the nail is involved, then this is known as distal lateral subungual onychomycosis. If only proximal part is involved, then this is known as proximal subungual onychomycosis, and if only superficial part of the nail plate is involved, then this is superficial white onychomycosis. Then sporotrichosis, I told you, initially at the site of inoculation a nodule develop, and then along lymphatics multiple nodules start developing. So if linear row of nodules is seen, then this is known as lymphatic variant of sporotrichosis. While chromoblastomycosis presents with a rough keratotic plaque, and gradually it becomes very large cauliflower like, as you can see this large cauliflower like growth present over distal extremities. Here again you can see rough keratotic growth of chromoblastomycosis. Then in chromoblastomycosis, cigar shaped bodies are seen. These are known as copper penny or sclerotic or medular bodies. Okay, penny is for coin and copper because they are of copper color. So if you get such copper color coin shaped bodies, this is copper penny body.